Welcome to the Osteopathic Center podcast, and today we are going to talk about shoulder injuries, in particular rotator cuff injuries. Now, if you haven't had a chance, check out the first lecture. We started with one, and we're going to try to do one either once a week or once every couple weeks to keep chipping away and providing some quality information about not only teaching about an injury, but also what are the other options besides traditional orthopedics and exactly how to treat these things in a regenerative or integrative way. So shoulder injuries are super popular and very, very painful, very frustrating injuries. If you've ever injured your shoulder, you know exactly what I'm talking about. So the unfortunate part about the shoulder is we really can't not use it. Every single thing you do with your hand pretty much requires your shoulder. So think of reaching out in front to grab a door to open a door frame. You have to extend your elbow. In order to do that, you have to use your shoulder. So babying a shoulder is not really an option. You know, you can technically put it in a sling, but that's usually not in your best interest. You do not want something called a frozen shoulder. And if you've ever had it, you know how awful they are. And if you've ever heard of it, be happy that you've never heard of it, and also be happy that you don't really ever want it because it's awful. Let's talk about the most common injury to the shoulder, what it is, how it happens, how common it is, and exactly what we can do to make it better. So the rotator cuff is a group of 4 muscles on each of us have on each of our shoulders. So I have a couple models here. I got my skeleton buddy behind me. Here's the shoulder blade. Okay? So you can see how each of these muscles is kind of coming together. You can see the tendons kind of reaching over here to the shoulder in the back. You can also see a lot of these tendons. This is the AC joint up here, which is right here on us. You know, we're really looking at each of these white right here. So the red is muscle, which heals really well if you strain it. That's traditionally what happens. But the problem is if it's the white part is the tendon. So it goes bone, muscle, tendon, bone. That's traditionally, so the tendon has to attach between muscle and bone. And that's the rate limiting factor when we traditionally have an injury. Think of the tendon as almost like a piece of rope. That is what's going to fray. It doesn't really tear and then heal. Because it doesn't have a good blood supply, it just continues to fray. So say it's supposed to be an inch wide. And whenever time you lift up your arm, it says, all right, no problem. I lift up the arm and whatever you're asking me to pick up a pull, I do, I can handle it, and then I go back down. Okay, great. But what happens if you have a partial tear of that tendon? So now say it's only 75, 3/4 of an inch. You lose a quarter of it. Now you're asking 3/4 of a piece of tendon to do the work of a whole tendon. But what if the remaining 75% is pretty beat up? It's there, but it's still pretty beat up. Maybe you're only at 50% of the strength. So now you're asking something that has less than full strength and less than full thickness to do something that a full thickness should do. Over time, it's just going to start wearing down, breaking down, and eventually tear even more. That's the problem with the rotator cuff, is that traditionally, because we use it all day, every day, you don't have a choice but to injure it slowly. But we can make it much worse. So how do you make a rotator cuff injury worse? What's a common way to do it? Slip and fall and try to break your fall with the natural way of just accidentally putting your arm out in front of you to prevent smashing your face on the ground? Well, that act, usually trying to break your fall, takes a chunk or piece of that rotator cuff off. Now, I've seen some bad ones that went from completely normal to full thickness tear, and then we've just seen some that were angry for a couple weeks and then come back down. If we look here at my little model buddy, you can see that there are 4 rotator cuff tendons. So we have these 2 right in front here. We have this one on the side, which is the main one. And then we have 2 in the back that are kind of grouped together. These are all very important. They all serve their own role. The main 2 in the front here are what I call the big boys. This is the subscapularis. This is for the motion to kind of like grab your seatbelt, like across your body. That's that motion. And then the supraspinatus is the one that almost all of us injure, because that's the one we use probably 70% of the time. I mean, it is very common. That's pretty much all we use is the supraspinatus. Anytime you reach out in front, anytime you pick something up and try to lift it out in front of you. I used to ask this question all the time to my patients. I would say, does it hurt when you lift a gallon of milk into the top shelf of your fridge? And they would say either yes or no. And I would say, if the answer was yes, and then I said, well, do you use your other hand to kind of support the milk or water, whatever it is, to put it on there? Well, if that's the case, then your tendon is not strong enough to lift 5 pounds or 8 pounds, whatever the weight of that jug is. So the problem is, when you are out here, you are completely vulnerable. You don't have anything else to use. That's the problem with rotator cuff, is that when it's isolated, that's it. That's all you have to use. When we have those arms back close to us, we have back and we have core. But once they're extended, it's all rotator cuff. So you have to strengthen these up as much as you can. And if there's a partial injury, you want to treat it sooner than later. The longer you wait, the bigger the injury is going to be, and the more, medicine / injection / surgery is gonna to fix this. This is something that if you address early, you can catch it and you might be able to nip it in the bud. But if you wait too late, you're going to have to throw the kitchen sink at it, and you still might not be able to be happy with it. The other 2 in the back, the Teres minor and the infraspinatus, are very large muscles, but they don't do a whole lot. They're more supplemental, and they have very specific ranges of motion. We really don't worry about them. You can injure them. Not super common. What are the most common ways to diagnose a rotator cuff injury, at least from imaging perspective? X-rays are going to be fine, but usually you're not going to see anything on there. You can have a bone spur underneath the shoulder, the lip of the shoulder right here, that can partially tear the rotator cuff. So every time you bring your arm up, it starts to kind of trip and almost clip that rotator cuff tendon. That can happen. Usually we don't see that, and if you do see it, that's an old injury that you've been dealing with for a long time. Traditionally, there are 2 ways that we diagnose rotator cuff injuries. The most common way is an MRI. Usually you do not need contrast with that. The other way is with an ultrasound. Ultrasound, not everybody does. I happen to do it. Dr. Goddard happens to do it, but there's not a whole lot of physicians who are trained properly to read these and also to be able to decipher what it looks normal, what looks abnormal. A lot of people will just defer immediately to an MRI because they are still considered the gold standard. But what you have to understand is that MRIs are not as sensitive as ultrasounds. Ultrasounds can pick up minor injuries that you're not going to get on an MRI. So a lot of times we'll even do both. You have any big tears or anything deep that we can't see with an ultrasound, and then we use the ultrasound to fine tune and say, oh yeah, that's where the injury is there. Oh, that one's a little partial tear. There's a little calcium there. There's a little scar tissue there. And then even more so when we're treating these, and I'll tell you about this in a little bit, we use the ultrasound to guide the needle into place. So the primary issue with rotator cuff is that they drive us crazy. We can't not think about these, especially at night. So you're probably wondering, what does rotator cuff pain feel like. Most people that tell me they have throbbing, aching pain at night that sometimes goes down the side of the arm, or they're trying to lay on that side and it just throbs. Another one I get often is that they're moving their arm like around their head. They just keep moving it until they find a position that is finally comfortable. If this applies to you, you have a bad rotator cuff. And really what happens is that tendon is throbbing because it's been overworked, it's overused, and the body doesn't have the necessary nutrients to deliver it to heal it. So it's letting you know. And in my mind, I almost feel like you've been busy mentally all day and you really haven't had a chance to think about your shoulder. Well, you're usually not busy at night when you're trying to sleep, and that's when it decides to come out and just goes woo, woo, and just drives people crazy. If that's the case, then you're going to have a heck of a time sleeping, and you're not going to recharge well because you're not sleeping well because you're in pain. So it's a vicious cycle. What are some of the traditional ways to treat this? Physical therapy can be very effective. Sometimes it's not enough, and sometimes you need help before the physical therapy can be effective. Can you have surgery on this? Yes. Can you put a cortisone injection in this? Yes. Does the cortisone injection help with pain? Yes, usually. At least the first time. What happens after the cortisone wears off in the surrounding tissue? The pain comes back. You are not structurally changing anything. You are just masking the pain and telling the brain, hey, you're not in pain right now. Once that medicine goes away, guess what comes back? Because the tissue is still damaged and still beat up, and actually even more beat up because you've been using it and you don't have pain to tell you, hey, don't use it. So you push through, you're using a beat up tendon and beating it up even more. And then when the medicine wears off, you're like, oh boy, exactly. What about surgery? Surgery for the rotator cuff is effective, very effective. But oh my, is it a long journey and a very challenging surgery and rehab. Most of the time, if it's just a little beat up, one or several of the tendons, they're not going to do a full rotator cuff repair. Because if they do, the surgeon would have to basically cut the entire tendon and retie it in and screw it back into the bone. Here's the problem. That screw takes a while to settle in place before you can start using it. So realistically, you're probably going to be in a sling for 6 weeks or so. I don't remember the exact protocol, but it's not like a week. It's several weeks. Then you slowly start ramping up in the once the screw has stabilized. What happens if you start using that shoulder immediately after that screw is placed in? You're going to pop that screw and pull that screw right out of the bone. And guess who has to go back to the OR? It is a long journey. I've seen rotator cuff repairs take 6 months, 9 months. Best case scenario, 3 to 4 months, I think, is probably if everything goes perfect. And you still may not feel super confident until, 6 months down the road. It is a long journey. Sometimes it's the only journey. Okay, so what other options are there, and what can we do here at the Osteopathic Center or any place that does regenerative medicine injections? What can we do to help rotator cuff? So rotator cuff should be addressed as soon as possible. The milder the injury, the earlier and the easier you can get away with lesser, stronger products. The stronger the product, the worse the injury. You can throw the kitchen sink at it for a mild injury. It may be a little overkill, but that's fine. But the opposite is not true. For a severe injury, you can't throw a mild product at it. It's not going to do anything. You're just going to waste your injection and waste your money, but you're not going to feel the benefit that you're looking for. Okay, So if you only have a mild rotator cuff strain, you could put a little bit of prolotherapy, which is a combination between dextrose and lidocaine. Mild stimulant helps to create a little bit of local inflammation, thereby recruiting tissues, recruiting the cells to help build new tissue, and it starts the healing cascade process. It's not a super potent injection. It's not going to, fix bad injuries, at least not with one round. And most of the time, they're going to need a couple rounds. But it's not super expensive, and it helps. It definitely helps. There's no question. Okay, what is the next level above prolotherapy, where most people will get great progress, have substantial improvements, and may even be able to do a one-and-done injection? That's PRP, or platelet-rich plasma. That's where we take blood out of our arm, your arm. We take the growth factor-rich layer after spinning it in a centrifuge. We collect it. We then numb up the area, usually under ultrasound guidance. Find the exact area of injured tissue. You see it right on the screen. You put the needle right into it. You numb up the area. You put the PRP in back, in the same area a couple minutes later. PRP is 3 times as strong as prolotherapy. Is natural. We're coming from you. But it is quite inflammatory. It's about a week or so. Some people are only a couple days. Some people a little bit longer than that, where they have a decent amount of inflammation and they're in more pain than they were before the injection. But this is all for the benefit of you getting better. So you kind of have to bite the bullet and know that you're making positive change, and you're just going to be in pain for a couple of days. And with each day, you get better. And by 3 weeks, most people are feeling very good, and they feel like they've made progress. Now, not all PRP is created equal. There are several different companies that create different types of centrifuges, different types of kits that will extract different layers of the cell in different quantities of the cell. And in that regard, that's why the prices are going to fluctuate. The prices are also going to fluctuate depending on how much blood they draw, depending on the technique of the skill of the physician, several factors. But in general, it can range anywhere from $300-$400 for a cheap kit to $1,500 for a really good kit. And everyone's a little different, but they're all very similar. But in general, the generalized technique is the same, but the skill of the physician that's injecting it, whether it's on ultrasound guidance, and how many areas they inject are unique to that practice. So you can't give a generalized statement. Okay, what is next after PRP? All of these are used to create rotator cuff injury. You have to treat this injury very seriously, because as you know, this is a very painful injury, and if you don't, it's just going to continue to linger, and at that point, it's only going to get worse, and you're going to be even in more pain. So realistically, if you have a bad tear, or you have an injury to the labrum, which is the ball and socket, the cartilage that holds the ball into the socket, you have to usually use something stronger than PRP. You have to use something in the stem cell line. If you don't, you're not going to get the progress you're looking for, because the labrum does not heal. It does really not stabilize with any products less than a stem cell line. We just have not had good luck with it. At that point, you either have to do bone marrow, you can do adipose, or you can do any of the allografts. So you have amniotic tissue, you have something called exosomes. Those are all possibilities. The theory is the same. The potency of the product is just a lot more strong, and you're doing the same exact thing. You're going to inject it into the same area of injury after numbing it up. The important thing is address the injury properly, make sure you get a proper diagnosis, and know that regenerative medicine works for this beautifully. You do not have to be miserable in pain. and you do not have to have surgery if you don't want to. There's a couple exceptions to that rule, though. Think of the rotator cuff tendons as being under tension. Okay, so the tendon is supposed to be here, and it rides all the way up. But if it's torn, now it's going to go zoom, almost like a tape measure when it goes back a little bit. The problem is you need to pull that and tack that back into the bone. If it has been what we call retracted, regenerative medicine is not going to be enough. Those people have to have surgery if you want that tendon back where it belongs. That's the only way. You have to tack it back down and put a screw into the bone. Or if it's a full thickness tear, or you have really bad arthritis in the shoulder, a lot of the times the surgeons, instead of repairing, will replace the whole shoulder, either a traditional or what we call a reverse shoulder. All of these options can be applicable. So this is not a one-stop shop. Every single situation is unique to that patient because their shoulder is different than my shoulder, that's different than your shoulder. So you have to individualize it. You can't say, this is what we do for everyone. It doesn't work that way. I hope you found this helpful. If you like this type of content, do me a favor and hit the like button and subscribe to the channel. We will see you soon. Take care.